So the first question is asthma an equivalent to an allergy, or is it just a chronic inflammation of the airways? Can you help describe it a little bit better?
Asthma, you do have some chronic inflammation of the airways, but in many cases, that inflammation, if you look at it, are these eosinophils, which we associate with allergic disease. In fact, even in the cases where you aren't able to diagnose allergies as a trigger, they still have those eosinophils in the airway. So the inflammation is still the same. And for instance, there's one group of asthmatics who react to aspirin or the other, what we call non-steroidal anti-inflammatory drugs like ibuprofen. That group, it's not through Ige antibody, but they still can have bad asthma and they will still have those eosinophils in the airway. So it's that inflammatory response in the airway which is still critical for asthma.
So are nasal steroids safe to use in children over an extended period of time?
I'll let the ones who see kids answer that, but yeah.
The simple answer is yes, so especially with the newer varieties which get very little absorption systemically. There's some risk of nosebleeds with all of the products, but in terms of effectiveness, the nasal steroids are still probably the best single medication for dealing with nasal symptoms related to allergy.
Yeah, there's also been some, when these nasal steroids came out, there were some studies that were done where they put kids on a nasal steroid every day for 1 year straight, and they monitored them, and there was really no significant side effects that was noted in them. So it really is a very topical product, does not get absorbed significantly into the body.
Yeah, they looked at things like growth in kids, which of course is always a concern, and growth in children with both inhaled steroids for asthma and nasal steroids hasn't been a problem. The initial studies, depending on the steroid, suggested maybe they have a temporary little decrease in growth, but they caught up again, and there was really no difference a number of years later. So that wasn't a factor, and with more recent steroids, they haven't shown any effect on growth, actually.
So why are environmental allergic reactions and treatments so different than the reactions one gets from and the treatments for food allergies?
Well, with environmental allergies, remember you're breathing them in, so your reaction is going to be more in the nose and eyes. You get exposure first to like the pollen or dust mite or animal dander, or you get the reaction in the lungs. You're not going to get really a significant systemic type of reaction where you break out in hives or throat swelling, the type that you get with food, because with food you're ingesting it into your body. Okay. Mind you, with inhalant, if you're rolling around in a grass field, yeah, you could get some hives on your skin. So that's part of the reason. There's also why certain foods cause more dangerous reactions than others. Like peanut, very minute amounts will cause more life-threatening reaction than some other types of foods, even though that potential is always there. And that's still not clearly understood. Okay. In terms of treatment, for environmental, you're exposed to it. During the pollen season, you're exposed to it day in, day out for months. So the treatment is aimed kind of at suppressing those symptoms. For food allergy, it's avoidance. Because the reaction can be so dangerous, so life-threatening. It's not like you can take an antihistamine, go out and eat the food you're allergic to. It doesn't work that way. You have to avoid it because there's always a risk that you get a severe life-threatening reaction to the food.
Okay. So someone had a question around anaphylaxis to foods and wondered if there was a score or a blood test to show anaphylaxis reactions. Someone was told something about a score of 17 or higher. Is it something you're familiar with? Or have you heard about a score?
I think that may be referring to the blood test, I think.
Okay,
yeah. Things when our labs measure allergy antibody to a specific food, it gives you a number. Now, that number doesn't tell you severity. That number just tells you whether you're at risk of getting a food, if you're allergic to that food or not. Okay? So a very high number means that there's a very high chance you're allergic to that food. But it doesn't tell you the severity. of the allergy. But we consider any food allergy, if it's a direct food allergy, to be severe. You cannot predict what kind of reaction you're going to get. You could get a mild reaction on one exposure, mild reaction, and then all of a sudden full-blown life-threatening. Sometimes you can see it escalate, but there's a bit of unpredictability. So anyone who's got a food allergy, we tell them, this is a potentially, life-threatening reaction you could get, strict avoidance. That number is just a probability, are you allergic or not?
A number of groups who are looking at do people grow out of peanut allergy are using a cutoff there where they won't even consider if it's very high, just because the likelihood is really high. If you're below that 15, or 17, is kind of a cutoff, which has been used by a number of groups to say, well, yes, in a supervised setting, we can give a challenge and see if maybe the child is no longer allergic to peanut. And in general, I think we can say that from numerous studies, the incidence is about 10% may actually lose their sensitivity or where it isn't significant. That still means 90% don't, and that's the worrisome thing.
Do you have an opinion on the homeopathic remedy for pollen allergy called Pollen Guard?
As per most homeopathic remedies, they often have a very, very dilute solution of the treatment that they're trying to apply. I believe with Pollen Guard there are some extracts of pollen, and usually at very, very low concentrations. And I think the evidence of double-blind studies that we insist for prescription medications and all of the brand name pharmaceutical over-the-counter medications really just haven't been applied here. So we know when one does a test for any medication, there's often a placebo benefit to the patient, and in some cases around 30% of patients will perceive a benefit even though it doesn't contain any active ingredients.
If you are taking Singular and need to take an antihistamine in addition for long term, is there any harm that an individual should be concerned about?
I don't think so. In fact, the companies involved at one time were considering putting the two products together. So they were thinking of using loratadine, which is Claritin, and Singular, into one tablet. Interestingly, they both can be of benefit even for eye nose symptoms, and maybe roughly comparable benefit. But when they put the two together, it didn't seem like the combination was really any better than either one alone. In the study, often Singular did better for the nighttime aspects, but the recommendations are usually to take it in the evening, so it may be more effective at night. There's actually no rationale to take the Singular in the evening versus the daytime. So why that's still in their recommendations, I'm not sure. And the one side effect we do see with Singular sometimes is vivid dreams if you take it in the evening. So that can be good or bad, but for some people it's terrible, very frightening. And if they take it in the morning, they don't get that. So you can get around it by actually taking it in the morning. But otherwise, Singular is a very safe drug, and it is an option.
You had talked a little bit about upcoming drug options being considered for peanut allergies, and folks were wondering about that.
Yeah, there's some studies that looked at, it's called an anti-Ige antibodies. So it's an antibody that actually binds to the Ige allergy antibody and kind of takes it out of the system. There were some initial studies that were done several years ago that held some promise. From what I recall, I think they tried to progress with some other studies, but they had some kids who reacted badly during some subsequent studies, so there was a bit of a kind of a delay or a holdback with this product, and now they've looked at it again. And I think it's still in the experimental stage. And it's just it's a product, it's an injection where you're given it presumably every 2 weeks or once a month, and it kind of keeps the allergy antibody down so that if you get accidental exposure, you may not react as badly. It doesn't cure you of the allergy.
So this, in a way, could function as a follow-up to that question. It's is lowering IgE the cure for people, and is it through IgG therapy? So they just wanted to understand that a little bit more.
The cure would be actually not just lowering it, but eliminating the Ige antibody. Because for those of us who don't have an allergy to peanut, we don't have the allergy antibody to peanut. Okay. There are a lot of treatments that are looking into how that can be done, but there's nothing yet that's been successfully proven. IgG, this anti-IgE therapy, it's kind of a hybrid type antibody that's produced. So it is a type of IgG antibody that takes that, but it's a very specifically manufactured antibody. It's not something that our body naturally produces.
Some of you may be aware of it it's indicated for severe asthma. So it's, we do have patients on it, and it does reduce Ig. It binds Ig, and you eliminate it so that the total Ig in your system goes down. It just doesn't go down enough. So for some asthmatics, it's been a huge benefit. But it's a very costly endeavor. So being a biologic compound, it costs about $15,000 to $25,000 a year probably. So you need good extended medical, which then covers it. But some people now are starting to worry about their lifetime costs going up, what they're really covered for on a lifetime basis when you've got an expensive drug like that.
Do we know what makes some allergies go away as in outgrow them? Like, why does that happen? Why do certain allergies do people grow out of?
I think partly it relates to the allergen per se, and as Dr. Kanani mentioned, that certainly in children with cow's milk and eggs, there's a very good chance that they will lose those allergens, and partly it's related probably to the chemical structure that caused the allergy reaction for those particular proteins in the first place. Generally, with environmental allergies, those tend to persist through one's lifetime. A good part of the time, I think in part because you get this continual annual seasonal exposure that reinforces your allergic response. We know that with aging there is some diminished allergic response, but we're looking at 70s, 80s plus, not your 50s or 60s by and large. So with some allergens, if you're able to avoid them over an extended period of time, for example, there's good evidence that for penicillin allergic children, that if they had a reaction early in their lifetime, that by the time they reach adulthood, there's a significant number that will lose their allergenicity, presumably just because they haven't had any further exposure to boost up their allergic response.
So the final question's not really a question, it's just a comment and clarification. Someone in the audience wanted to clarify that BC does not have a law for schools to deal with children at risk of anaphylaxis reaction. We have a ministerial order, and the compliance varies from district to district. Probably somebody who has a kid.
I've actually been sitting on the committee evaluating the school response from the Ministry of Education, and it was introduced in a hurry in British Columbia. The fact it's not a law as opposed to just it being an administrative directive from the Minister of Education, I think doesn't tend to diminish the responsibility for school boards and individual schools to implement policies. And say this, we're under work now to try and come up with a means to monitor all the schools and school districts to see if they are complying with what the minister had wanted, and how effective is this in actually reducing anaphylactic reactions within the school setting.
Are there any other questions in the audience? Yeah, go ahead.
I think it's not an uncommon phenomenon for women that the onset of their allergies seems to be worse after pregnancy, and whether it's related to the hormone changes related to pregnancy, I think a lot of the time it's pregnancy is beneficial for environmental allergy control, and that women go through a season in their pregnancy and have very little symptoms because of that protective extra cortisol your body's producing in the pregnancy, and then the next year is when you really feel it. You don't have that extra protective hormone benefit. I think that, as Dr. Schellenberg mentioned, there's often some sort of trigger factor that comes on. And maybe pregnancy could be the trigger factor. I don't know. There's really good evidence for that, but it's not an uncommon story to hear that women date the onset of their allergies after their pregnancy.
Go ahead.
Is there a link between lupus and asthma and allergies?
No, in terms of autoimmune disorders and allergies have often been thought to be polar opposites, but that doesn't really hold. So part of this is this aspects of what we call Th1 and Th2. So your helper T lymphocytes have a tendency to skew for allergies to this Th2 ones, which make IgE, and more to Th1 for more of the autoimmune disorders. But there's good data that you can have both, but it's not common. They're certainly not linked. There's no excess of one or the other. I think.
So the question is diabetes, autism, and allergies seem to be increasing in prevalence. And is there any link with that rise?
Yeah, again, there's epidemiological studies that have shown that several other diseases as well, like Crohn's disease and things like that, have been increasing. I remember seeing one study where it showed all of these diseases that you talked about steadily increasing, and a graph right next door is showing all of these infectious diseases coming down. Parasitic infections, TB, all of that was affected coming down. So there was an implication that it had to perhaps do something with that there's a shift occurring in our immune system. Diet has also been felt to play a role in many of these conditions as well. But again, it's right now it's just general epidemiological.
It's certainly a complicated question. It's probably not one factor involved in that. Go ahead.
Yeah. No, that's true. You're right in terms of how accurate is the data we're getting from each country. And that has been a limitation for some of these studies. But there are other studies where, they actually go to a certain community. So the investigators check one community, and then they go to another community in that country and they check. So it's the same investigators checking both that have shown some difference going on. There's a good study that compared a city in Finland to a city in Russia. And the city in Finland had, very high rates of allergy to environment and food, very negligible in that same kind of city. They tried to compare them. They were otherwise relatively equal type cities, and very low rates in the Russian city. And so they're kind of also showing not only this developed countries versus developing country difference, but also west versus east kind of difference as well going on a bit.
There was a famous one in terms of Germany before they amalgamated that it was actually East Germany had much more industrial pollution and so forth, and yet it was West Germany that had the high incidence of asthma. And since they've amalgamated, it seems like the East Germans are starting to be very similar in terms of that. So what are all the factors going on? Although probably there were more Mercedes and diesel exhaust particles in Western Germany than Eastern Germany, I don't know, but there may be other factors involved certainly with that.
Go ahead.
I'm just curious, you mentioned that.
Well, it's a committee set up to try and develop the tools to monitor, and nothing has been definitely agreed to at this point. But there's a number of ways that principals will have to be putting out reports, and the school boards will have to provide this all to the Ministry of Education, and this overseers will review the data and see that they going through the checklist of all the appropriate procedures and policy are being followed.
Would you have parents on that team that are also interested in how?
On the committee, there are members from Anaphylaxis Canada, Allergy and Asthma Information, so it's a fairly broad-based committee. It's not just school board and Ministry of Education officials.
So I think I'll close the formal question period and invite you to have some light refreshments. We have some cookies and some beverages, and some of our speakers will stay around and we'd be happy to meet you and talk to you. I just would also like to highlight that our next session is on April 21st, and it's on lipids. So it's the people from the prevention clinic. So they look at heart health. So it's not just about cholesterol. It's about sort of all the factors to improve your cardiovascular health, and it's focused from a prevention perspective. And there's also going to be a dietitian who will attend that session as well. So again, I would ask you to let your friends know, let your family know, or anyone who's interested, and we invite you to come back on April 21st. So thanks very much.